Let's now discuss how and why the sodium concentration is tightly regulated. Recall from prior modules that water is distributed among different fluid compartments in the body. Total body water comprises 60% of a person's ideal body weight. Total body water is divided into intra and extracellular fluid spaces. Water moves freely across the semi-permeable membrane between the intra and extracellular fluid spaces. Sodium does not move freely across the membrane. Therefore, sodium exerts an osmotic effect across the membrane. Water will move from lower to higher concentrations until osmotic equilibrium is reached. At equilibrium, the concentration of sodium in the extracellular space is about 140 milliequivalents per liter, compared to 10 milliequivalents per liter in the intracellular compartment. The sodium concentrations are not the same. However, the net effect of osmotic and oncotic forces from other molecules maintains intracellular and extracellular equilibrium. Because changes in sodium drive fluid shifts, the body must tightly regulate sodium and water balance to avoid dangerous shifts between the fluid compartments. As an example of why tight control of water and sodium balance is essential, consider brain cells under varying sodium concentration. In acute hyponatremia, as you recall is a water excess, the osmolarity of the extracellular space is decreased due to a high ratio of water to sodium. In this example, we use 110 milliequivalents per liter serum sodium concentration. To restore the prior osmotic balance between the intra and extracellular spaces, water will move to the intracellular space. With the movement of water into the intracellular space, brain cells swell, causing cerebral edema. As you know, swelling of the brain can result in devastating neurologic complications. Said complications include confusion, nausea and vomiting, fatigue, generalized weakness, seizures, coma, and death. Three main hormones regulate the essential sodium and water balance. They are antidiuretic hormone, ADH, also known as arginine vasopressin, AVP, aldosterone, and the antinatriuretic peptides. This module will focus on the role of ADH, which is a hormone that regulates water balance and vascular resistance. ADH is produced in the hypothalamus. It enters the systemic circulation through the posterior pituitary. The primary function of ADH is to signal the kidney to reabsorb water and stimulate an increase in peripheral vascular resistance, aka systemic vasoconstriction. The overall effect is to limit water loss and improve effective arterial blood volume. Two main conditions stimulate the production and release of ADH. 1. High plasma osmolarity, and 2. Low blood pressure, also known as low effective arterial blood volume. The most common example of high plasma osmolarity is hyponatremia, or a high serum sodium concentration. Recall, hyponatremia most commonly represents a water deficit, but it could also be a sodium gain. Either way, it is considered a concentrated solution. Osmosensors in the brain serve to detect high plasma osmolarity. Arterial baroreceptors in the carotid sinus and atria detect low blood pressure. Let's explore more in detail. The primary and most sensitive driver of ADH release is plasma osmolarity. When the plasma osmolarity rises above physiologic conditions, osmoreceptor neurons in the hypothalamus, represented by the star, sense the change and trigger ADH production. ADH is released by the posterior pituitary and goes on to stimulate reabsorption of water by the kidneys, which we'll discuss mechanisms of in a later module. We cannot forget that hyperosmolarity also stimulates an intense thirst mechanism. The increased water ingestion and reabsorption of water dilutes the sodium concentration in the plasma to a normal range, bringing sodium osmolarity levels back within range. What do you think the urine osmolality would be in a patient with hyponatremia with a serum sodium of 155 milliequivalents per liter? To answer this question, you must first understand the kidney's urine dilutional and concentrating capacity. In a functioning kidney, the kidney can dilute the urine to an osmolality as low as 50 milliosmoles per kilogram. That's urine that is mostly water. It can concentrate the urine to as high as 1200 milliosmoles per kilogram. That's practically no water. So, in this setting where we have a hyperosmolar state, where presumably ADH release mechanisms are intact, we should expect ADH release and water reabsorption by the kidney, which concentrates the urine. Therefore, the urine osmolality should be high. The second main trigger for ADH production and release is a significant drop in blood volume or pressure, also known as low effective arterial blood volume, EABV. Pressure sensors, called baroreceptors, located in the carotid sinus and the aorta, sense the change and send neuronal signals through the vagus nerve, thereby stimulating ADH release. ADH subsequently stimulates absorption of water in the kidneys. ADH is also known as arginine vasopressin, AVP, and its other role is to act on receptors in peripheral arteries to cause systemic vasoconstriction. While unrelated to ADH release, we would be remiss if we didn't mention one last important reflex related to high osmolarity. The same osmoreceptors in the brain sensing high osmolarity also stimulate an intense thirst response. As long as a person has an intact thirst mechanism and they have access to water, they will and can drink high volumes of water to return serum sodium and osmolarity back to normal ranges. A final known stimulus for ADH release is direct stimulus from angiotensin II, a downstream product from renin. Let's now examine how ADH is influenced in low EABV states. For background, a low serum osmolarity is most often represented by a low serum sodium concentration, like hyponatremia. In this setting, ADH release completely shuts off. However, the exception to this rule is in the setting of low effective arterial blood volume states. What happens here is that the stimulus for ADH release overrides the low osmolarity ADH shutoff. If ADH were shut off in a patient with a serum sodium of 120 milliequivalents per liter, what do you expect the urine osmolality would be? In this case, assuming the patient is not hypotensive, we expect there to be no stimulus for ADH release, thereby no stimulus for water reabsorption by the kidney. This should result in very dilute urine and a low urine osmolality. The ADH axis can be thought of as a feedback loop. If the serum sodium concentration is lower than normal range, this is typically water excess, less commonly sodium loss. Where ADH is suppressed, resulting in increased renal water excretion. Thirst is also suppressed, resulting in decreased water intake, returning serum sodium concentrations back to normal. Conversely, if the sodium concentration is higher than normal range, which is a water deficit or less commonly sodium gain, ADH release is stimulated, resulting in renal water reabsorption. Thirst is also stimulated, increasing water intake. Again, these actions return serum sodium concentrations closer to normal.